So what is heart failure? Heart failure is a common and serious condition that develops slowly over time, and your heart becomes weakened and cannot pump enough blood to meet your needs of your body. So heart failure is caused by coronary artery disease, high blood pressure, and valvular disease, myocarditis, and dilated cardiomyopathy, and congenital heart disease. All cardiovascular disease can be a cause for heart failure. Heart failure patient shows fatigue, shortness of breath, and without exercise, and in an end stage, they show wheezing after lie down. And a doctor diagnosed heart failure patient by physical exam, blood test, X-rays, ECG, echocardiogram, or other invasive tests, including catheterization. And once doctor diagnosed a patient as heart failure, then they treat the patient with a lifestyle change here, and medication, surgery, and non-pharmacological therapies, such as left ventricular device or heart transplantation. So heart failure is very common and serious disease. In developed country, heart failure is one of the leading causes for death. About half of people who have heart failure die within 5 years of diagnosis. 1 out of every 5 people at 40 years old will develop heart failure in their lifetime. So as you see, heart failure is very common and very serious disease. So recently, many therapeutics have been developed. However, we still have such a very burden disease. So we must develop novel and effective therapeutics to treat patients with heart failure. So how normal heart works? Heart beats regularly, approximately 60 beats per minute. And this is the cardiomyocyte, and this is the myofibril here. This is mitochondria, and myofibril is surrounded by a reticular component here, which is called sarcoplasmic reticulum. And sarcoplasmic reticulum face here to the teachable, which is an investigation of plasma membranes. And also has cardiomyocytes contain a lot of mitochondria, which supply ATP for contraction. So many studies have been done and show calcium is a key regulator for muscle contraction and relaxation. So this is a schematic schema. This is teachable. This is sarcoplasmic reticulum here. And this is myofibril. And this is calcium, L-type calcium channel here. This is sarcoplasmic calcium release channel here. And also, this is calcium ATPase in sarcoplasmic reticulum. So once plasma membrane is depolarized, very small amount of calcium enter into the myocardium here through L-type calcium channel. And the small amount of calcium then activate calcium release channel. It's another word called a ryanodine receptor. That calcium stimulate and open ryanodine receptor, and calcium is released from sarcoplasmic reticulum to cytoplasm. And this calcium binds to myofilaments and induce muscle contraction. And calcium ATPase here, calcium ATPase uptake calcium from the cytoplasm to sarcoplasmic reticulum and lower the calcium concentration in cytoplasm that resulted in muscle relaxation. So in heart disease, you will see increased hemodynamic stress that lead to contractile dysfunction and heart failure. So if you think of calcium is very important for muscle contraction, relaxation, abnormal calcium signaling might be a cause for heart failure. So many scientists studied the calcium signaling and identified a molecular entity for calcium signaling proteins such as renin receptor, calcium ATPase, and calcium channel. When I was a postdoc at Canada, I cloned a calcium release channel, calcium renin receptor in sarcoplastic reticulum. And these proteins consist in a hydrophobic N-terminal region and a hydrophilic N-terminal region and hydrophobic C-terminal region. And N-terminal region span between sarcoplastic reticulum and teachable, and C-terminal hydrophobic region form a channel. And calcium is come out through the teachable, and calcium is activate the calcium release channel. During this study, we found this isoform of this cardiac type of calcium release channel, skeletal type of isoform, is a cause for malignant hyperthermia. Malignant hyperthermia is a lethal genetic disease. And malignant hyperthermia patient shows abnormal response to administration of potent inhalational anesthetics. And they show an abnormal autosomal dominant genetic disease. And once they develop a disease, they show elevated body temperature, muscle contraction, tachycardia, and arrhythmia, and tachypnea. So at that day, we don't have any genetic diagnostic method because we don't know the lead cause for this disease. And similar disease exists in a pig. Stress-induced malignant hyperthermia-like phenomenon. When you put a pig in a farm into a truck and bring to a farm, market. Once you open the door of the truck, all pig like this, muscle contraction and high body temperature. And once pig develop this disease, the meat down here, the meat become very watery and cannot be sold. This is very big problem in agricultural area, especially in Canada and UK. So we analyze an amino acid sequence in diseased pig and normal pig, and find out only one amino acid mutation here, arginine to cysteine, is the cause for this disease. And then we develop the diagnostic test. So nowadays, we don't have any malignant hyperthermia pig in the world, including UK. And also, this mutation was found in human malignant hyperthermia, but human disease is so heterogeneous, we found thousands or hundreds of mutations. So still, we don't have enough good genetic test for malignant hyperthermia. So, as I said, at that time, calcium, everybody in cardiology studied calcium signaling in a cardiomyocyte. And based on that findings, pharmaceutical company developed a lot of positive inotropic agent. However, with the exception of digitoxin, no inotropic agent has been associated with favorable effect on outcome. So, and this is 1999, this is very surprising clinical data. They treat patients with beta blocker, which suppress cardiac function. But as you see, beta blocker improve survival of heart failure patient. So we should change all concepts at this point. By the way, as you may know, beta blocker is invented by Professor James Black, and my office is his office. I'm very proud of that. So anyway, so before we thought heart failure is characterized by impaired contractility and congestion here. And treatment, therefore, is digitalis and diuretics to increase the contractility and improve the congestion. However, now concept has been changed completely. Heart failure is considered as an abnormality in systemic circulation, which is caused by abnormal activation of pneumofemoral factors and cytokines, including angiotensin II, catecholamine, endothelin, and tumor necrosis factor. So now treatment is to inhibit these pneumofemoral factors and cytokines, such as angiotensin II converting enzyme inhibitors, angiotensin II receptor antagonists, and beta blocker. So what is cause for the heart failure now? We know not abnormal calcium signaling or abnormal cardiac function. So heart disease includes mechanical load, which mechanical load activate pneumofemoral factors and cytokines, as I said. And these cytokines and pneumofemoral factor activate intracellular signaling pathway and leading to heart failure. And all current therapeutics targets to the activation of pneumofemoral factor and cytokines. So question is, how these pneumofemoral factors and cytokines activate intracellular signaling pathway, and how which activate some cause for heart failure? That's a big question. So if you see a heart in a heart failure patient, this is the biopsy sample from heart failure patient. You can see lot of vacuole in cardiomyocyte here and fibrosis, which indicate in a failing heart, cardiomyocytes are dying. So if we can prevent this phenomenon, we may be able to treat heart failure patient. So there are two modes of cell death. One is apoptosis, another one is necrosis. Apoptosis are considered as an active cell death, characterized by cell shrinkage, chromatin condensation, and nuclear fragmentation. Necrosis considered as passive cell death, characterized by cell swelling, plasma membrane disruption, and nuclear shrinkage. So this is a tunnel staining to estimate apoptosis in failing heart. You can see that lower panel, that tunnel positive cell indicate apoptosis actually occurring in a failing heart. So apoptosis may mechanism for apoptosis is in the mitochondria. And once apoptotic signal activated back in mitochondria, lead to a release of cytochrome C from mitochondria to cytoplasm, and cytochrome C activate caspase and execute apoptosis. So problem is, how pneumohumoral factors activate this apoptotic mechanism is a major question. So in a general scheme, ligand bind to receptor that lead to generation of second messenger. A second messenger activate directly or indirectly MAP3 kinase, then MAP2 kinase, and MAP kinase. Then MAP kinase activate transcriptional factors. So in that days, in the G protein coupled receptor, G coupled receptor, which is a receptor for angiotensin II and endothelin, produce calcium in IP3 dependent manner, and calcium activates PKC, and PKC activates MAP3 kinase RAF1, and then activate MAP2 kinase MKK1-2, and activate a classical MAP kinase ARC1-2. And the ARC1-2 activate AP1 in cardiomyocyte. However, this signaling pathway cannot explain the genesis of heart failure. And GNK and P38, which are stress-activated MAP kinase, and that might be involved in the genesis of heart failure. However, upstream and downstream signaling molecules were unknown at that point. So in another cell, we know ultraviolet radiation, reactive oxygen species, and osmotic shock can activate these stress-activated MAP kinase, including JNK and P38. Oops. So if you consider ROS, ROS is generated by mitochondria or NADPH in plasma membrane. So this is a normal mitochondria, left side, and right side is mitochondria in failing heart. So in failing heart, you can see swelling of mitochondria, and intramitochondrial crystal structure are severely damaged. These mitochondria release reactive oxygen species to cytoplasm, and reactive oxygen species directly damage macromolecule, including protein, lipid, DNA, and leading to organ damage and cell death. That is now considered as one of the causes for heart failure, as well as ischemia or reperfusion injury. So, substress, we know there are many reports, sub-resal stress, such as brief ischemia in this cardioprotection against ischemia reperfusion injury. So soon after brief ischemia or 24 after brief ischemia, we can see a decrease in infarct size by following resal ischemia reperfusion injury. And we found that not only ischemia, but also other subresal stress, such as exercise, hypothermia, LPS, also can induce cardioprotection against ischemia reperfusion injury. Then we identify the molecular mechanism for this cardioprotection, subresal stress cardioprotection. So subresal stress generates reactive oxygen species in cardiomyocyte. Reactive oxygen species can activate TNF alpha and IL-1 beta, which lead to an activation of manganese SOD, which is endogenous antioxidant, and this protects ischemia, reperfusion injury. So here, ROS is work as a second messenger, not direct molecule to give a damage to molecules. So at the time, we hypothesized that ROS also play a intracellular signaling molecule in genesis of heart failure. So if so, angiotensin II or endothelin can generate ROS in cardiomyocyte. So we load an ROS sensitive dye in isolated in cardiomyocyte and we load an ROS sensitive fluorescent dye and incubate with these reagent. So you can see here these angiotensin II endothelin phenylephrine actually can generate ROS in cardiomyocyte. So we then examine whether this is true or not in vivo system. Usually we use a pressure overload model by a transverse aortic constriction. So we made a constriction at the transverse aorta there, and this gives a pressure overload to left ventricle. So 1 week after this operation, mouse shows cardiac hypertrophy, and then 4 to 10 weeks later, mouse shows heart failure. So, I'm sorry. Oops. We measure MDA content. This is an indicator for oxidative stress. And you see in a third column, this is an TAC operator mouse hearts. You can see increased MDA content, suggesting pressure overload can generate ROS in the heart. So in vivo and in vitro study indicate such a stress can induce ROS in cardiomyocyte. So if pneumophenol factors generate reactive species, what is a MAP3 kinase downstream of the ROS? So we search in the literature and find ASK1. This is MAP3 kinase, which can induce apoptosis. And ASK1 form a heterodimer with thyroredoxin, and ROS oxidize thyroredoxin. Then thyroredoxin depart from the ASK1. Then ASK1 form homodimer. This is an active form of ASK1 and activate JNK and P38, leading to apoptosis. So we investigate whether ASK1 is involved in the genesis of heart failure in the cardiomyocyte. So we first examine the activation of ASK1. We incubate with an isolated cardiomyocyte with these reagents and measure ASK1 activity. You can see here ASK1 is actually activated by angiotensin II and endothelin. And this is activation, and if we pre-treated with an antioxidant, the activation is inhibited, suggesting ROS in ASK1 is activated by ROS-dependent manner. So next question is, what is a downstream transcriptional factor? So again, we search in literature. So NF-κB is the ROS-sensitive transcriptional factor. So first, we measure NF-κB activity here. So you can see angiotensin II endothelin phenylephrine can activate NF-κB. And this is ASK1, KM. This is a dominant negative form of ASK1. This inhibition of ASK1 can inhibit angiotensin II induced ASK kappa B activation. And ASK delta N, most right side, this is a constitutive active form of ASK1, can activate kappa B. So ROS can activate ASK1, ASK1 can activate kappa B. So this is a summary slide. I don't tell you in detail, but angiotensin II bind receptor, and that increase the calcium concentration in myocardium in IB3-dependent manner. And then calcium activate calcium-dependent tyrosine kinase PIK2. PIK2 activates small g protein LAC. LAC is recruited to NADPH oxidase, and NADPH oxidase generate ROS. ROS activate ASK1, GNK, P38, then kappa B. This is a novel signaling pathway. So, but this is just an in vitro study. So to know the role of this signaling pathway, we generate a series of knockout mice, and to know the role of the molecules in genesis of heart failure. So this is ASK1 knockout mice, and we subjected these knockout mice to pressure overload by means of a transverse aortic constriction. So 4 weeks after pressure overload, wild-type mouse show direct, shows heart failure. However, ASK1 knockout mice does not show heart failure phenotype. And we employed another heart failure model. This is an LAD occlusion model, because hypertension and myocardial infarction is the two major causes for heart failure. And wild-type mouse show chamber dilatation. However, that chamber dilatation and cardiac dysfunction is significantly attenuated in ASK1 knockout mice. And we measure the apoptosis, and you can see left side is a TAC model, a pressure overload model. Right side is an MY model, and wild-type mice, you show an upregulation increase in apoptosis. However, that red bar, that ASK knockout mice, show a decrease in apoptosis. Strange. So, and other example is P38. This we generate a flux cardiac specific P38 knockout mice, and this is the Cre recombinance is located under alpha MHC promoter. Alpha MHC promoter is a cardiac specific promoter, so Cre recombinance is expressed only in cardiomyocyte. And also we made a fluxed P38 and made these two mice. So only in a cardiomyocyte, the gene between the gene P38 flanked to flux site is excised. So we have a cardiac specific P38 knockout mice. So we subject this mice to a pressure overload, and 1 week after attack, P38 knockout mice shows just cardiac hypertrophy. However, control mice shows just cardiac hypertrophy. However, P38 knockout mouse here shows chamber dilatation and heart failure. So P38 has a cardioprotective against pressure overload. So how about kappa B? So we usually use echocardiography to estimate the cardiac function. So you put a probe on a chest wall, and here, and this is a broad echo generating interface, y-axis, and x-axis is time. So this is a septum, this is left ventricle, this is posterior wall, This is systolic phase, this is diastolic phase. So we can know the chamber size, also we can know the contractility. So this is control mice. 1 week after attack, you can see hypertrophy. But here, this is NF-kappa B knockout mice. You can see chamber dilatation. So NF-kappa B also work as a cardioprotective mechanism against pressure overload. So we repeat such a study, and this is a summary slide. So lethal stress generate ROS. ROS activate ASK1, JNK signaling pathway leading to apoptosis. Also, this signaling pathway activate NF-kappa B, P38, or calpain, and these molecules work for cardioprotection. So cell fate is regulated by the balance between this apoptotic signaling pathway and cardioprotective pathway. That's our conclusion. So if this is true, ASK1 might be a therapeutic target to treat a patient with heart failure. So we use a bio-T2 mouse. This hamster developed spontaneously heart failure, and after developing the hamster showed the cardiac dysfunction, we inject the dominant negative form of ASK1, which is cloned into an adeno-associated vector via coronary artery, and then observe the time course. So this is a control virus treated heart. This is an ASK dominant negative form treated heart. You can see control heart shows a chamber dilatation and decreased wall motion. However, if you inhibit ASK1, you can attenuate the development of heart failure. So now we are finding a small molecule which can inhibit ASK1 activity. So if we can get an effective small molecule, that molecule can be a drug to treat a patient with heart failure. So I told you necrosis is passive cell death. If necrosis is passive cell death, we cannot regulate because this is passive. However, we found necrosis is not passive cell death. Actually, necrosis is also active cell death. So responsible molecule for necrosis is permeability transition power in mitochondria. And cyclophilin D is one component for PTP channel. And when necrotic stimuli activate PTP, that increase permeability of mitochondrial membrane, which dissipate electrochemical gradient leading to necrotic cell death. So since we find that necrosis is not a passive cell death, but positive cell death, active cell death, we can regulate necrotic cell death, which is a mode of cell death in myocardial infarction. So we subject cyclophilin D knockout mice to 30 minutes ischemia followed by 2 hours reperfusion. So this is an upper panel is control here. This is cyclophilin D knockout, and white area is infarct area. This is a quantitative analysis. So this is a control mice. This is a cyclophilin D mice. We saw infarct size was significantly decreased by cyclophilin D aberration, suggesting even in myocardial infarction, we may be able to regulate infarct size by inhibiting necrotic things. So now we are also try to find a small molecule which can be inhibit cyclophilin D or TTP channel. So Recently, there are reported a third kind of cell death, which is autophagy. What is autophagy? Autophagy is known as the adaptive response for starvation. So upon starvation, or cytoplasmic organella or material, cytoplasmic material organella, including mitochondria, are sequestrated by isolated membrane to form double membrane vacuole autophagosome. Autophagosome then undergoes fusion with lysosome to form autorhexosome. And lysosomal enzyme degrade contents in autorhexosome to form amino acid and fatty acid to fatty acid. These can be reused by the cell for protein synthesis and ATP. So this is the survival mechanism for starvation. And many studies have been done to elucidate the role of autophagy. So this is summary slide. There is two kinds of autophagy. One is low level of constitutive autophagy. Another one is inducible autophagy by starvation. Constitutive autophagy is important for intracellular clearance, and inducible autophagy is important for inducible autophagy, nutrient regulation. So this is an EM picture in a heart section from heart failure, human heart failure patient. You can see here lot of autophagosome or autorhexosome structure. So what's the role of autophagy in failing heart? So we generate the cardiac spectrum ATG5 knockout mice. ATG5 is a very important molecule for autophagosome formation. So, and then we subject this mice to pressure overload. This is control mice. This is ATG5 knockout mice. So ATG5 knockout mice show chamber dilatation and cardiac dysfunction, suggesting autophagy is protective mechanism, not cell death mechanism. And this is a lower panel is an EM picture. So you can see this alignment of mitochondria and mitochondrial structure, intramitochondrial structure severely damaged. So autophagy is important to maintain cardiac function, cardiac morphology, and mitochondrial morphology against pressure overload. So there are two kinds of protein degradation system. One is autophagy, another one is ubiquitin protease system. Autophagy is non-specific degradation system, whereas ubiquitin protease system is in a selective degradation system. So protein is ubiquitinated, and then that ubiquitinated protein is degraded by 20S proteasome system. So this is TACMIN pressure overload control ATG5 knockout mice control. You can see upregulation of ubiquitination here. And also you can see upregulation of increase in apoptosis. So cells get stress, and if start to aggregate and degrade, if the amount of degraded protein is low, that protein is repaired by heat shock proteins. However, if it increases, that protein is degraded by ubiquitin protease system and autophagy, but failing heart, the aggregated proteins by stress is increased. So that aggregated protein can induce apoptosis and heart failure. So this is, again, summary slide regarding the role of autophagy in the heart. Constitutive autophagy is important protein control, and inducible autophagy by pressure overload is important to prevent heart against pressure overload. So we previously, in old days, we are fighting against acute disease such as bleeding, virus, and bacterial inflammation. However, now we are fighting against chronic disease such as obesity, metabolic syndrome, hypertension, IHD, or Alzheimer's disease, or cancer. So these studies suggest low level of inflammation is important in the genesis of these all chronic diseases. Heart failure is not exception. In heart failure, in heart failure patient, you can see an upregulation of inflammatory response in heart. So question is, in absence of microorganism, how inflammation occurs? So we focus on the mitochondria because mitochondria evolutionary endosymbions that were derived from bacteria. So mitochondria still has characteristics of bacteria. For example, bacterial DNA resembled mitochondrial DNA resembled bacterial DNA, being circular and having unmethylated CpG motif. This unmethylated CpG motif is known to be a very potent inflammatory response. So we hypothesize instead for the genesis of cellular inflammation, mechanical load increase damage of mitochondria, and that increase autophagy activity. But the level of autophagy induction is insufficient that lead to the mitochondrial DNA. Since mitochondrial DNA is very inflammatogenic, that induce inflammation and heart failure. So this is a section of a failing heart, mouse failing heart, and we stain a picogreen and anti-LAMP2A and anti-LC3. Picogreen is marker for DNA, LAMP2A is marker for lysosome, LC3 is marker for autolysosome or autophagosome. You can see in failing heart, picogreen LAMP2A positive dots as well as picogreen LC3 positive dots, suggesting in failing heart, DNA is accumulated in autolysomes. And how that mitochondrial DNA degraded, so we focus in DNase2, which is localized lysosome, and the nucleus that hydrolyzes a backbone of DNA molecule. And then we generate cardiac-specific DNase knockout mice and subject to pressure overload. And this is 10 days after pressure overload. This is DNase knockout mice. You can see enlargement and look some edematous. This is echocardiography here. Pressure overloaded DNase knockout mouse show chamber dilatation and cardiac dysfunction. This is a histological analysis. You can see pressure overloaded DNase knockout mouse shows the infiltration of inflammatory cell, including macrophage and neutrophil. So this is an EM picture. This is a DNase knockout mouse here. This is a control mouse. This is sham. This is a pressure overload. You can see here some electron dense deposit here. If you carefully see this structure, it looks like mitochondria in autolysosome. So looks like the mitochondrial DNA accumulated myocardium in response to pressure overload. So how that mitochondrial DNA induce inflammation in the heart? So we can go back to bacterial world. In a bacterial DNA, which contains a unmethylated CpG motif, can bind TL9 receptor and to induce inflammatory response. So we assume same things happen for the mitochondrial DNA in failing hearts. So we generate DNase2 and TL9 double knockout mice and subject to pressure overload. So this is a single knockout mice of DNase2. This is double knockout mice of DNase2 and TL9. You can see that single knockout mice of DNase2 shows an enlargement, chamber dilatation, and cardiac dysfunction. However, TLR9 aberration can attenuate development of heart failure. This is here. This is a single knockout mouse DNA2. You can see macrophage infiltration. However, this is a double knockout. That macrophage infiltration is significantly attenuated. So this is true. So to know the role of DNA, the TL9 signaling pathway, then we subject the TL9 single knockout mice to pressure overload. So this is a control mice here, 10 weeks after pressure overload, you can see heart failure, and also you can see macrophage infiltration. However, TL9 knockout mice prevent development of heart failure. So suggesting even this is a TL knockout mice, so suggesting this mice has DNase too. So even mice which has DNA2, TL9, DNA, TL9 signaling pathway play an important role. So we subject mice to wild type mouse to tag pressure overload and observe the survival. And we treat drugs, which is the TL9 inhibitor. You can see if you treat mice with TLR9 inhibitor, the survival ratio significantly improved. So this inhibitor is just oligonucleotides. Now we are developing, we now get a small molecule which can inhibit TL9. And we are now doing to examine the effect of this small molecule, whether that can be prevent heart failure or not. So that might be another candidate drug. So summary, so pressure overload induces mitochondrial damage. Damaged mitochondria is sequestrated by autophagy system. However, the degradation autophagy induction is insufficient. That so the mitochondrial DNA is accumulated in autorhizome. Then mitochondrial DNA bind to TL9 to activate inflammatory response in cardiomyocyte. And cytokines then go out of the cardiomyocyte and recruit, activate macrophage and neutrophil to lead enhanced inflammation. And that secondary enhanced inflammation lead to cell damage and heart failure. So today's my talk, so heart disease increased mechanical load and which activate pneumofemoral factors and cytokines that activate intracellular signaling pathway. And these intracellular pathway might be a therapeutic target to treat the patient. Also, these signaling pathway lead to cell death, such as necrosis and apoptosis. Also, regulating these cell death might be therapeutic target. So I can say heart failure is cardiomyocyte deficiency syndrome. So I did this work for more than 20 years and with a lot of collaborators. And the very important thing for scientists is to have very good collaborator. If you are not good, if you have a good collaborator, you can accomplish something maybe. And also these studies are supported by Japanese government as well British Heart Foundation and MRC. So as I was introduced, 2 years ago, I moved to Osaka University to King's College London. I enjoy this college very much, and I'm very happy someday I can work with you. Thank you very much indeed.